We have an exciting session planned for you today. My name is Daria Squirko. I'm from the University of Massachusetts in the U.S.
And my name is Lisa Cranmer with Emory University in Atlanta.
So just to make sure you're all in the right place, you're here for the short oral abstract session titled "We Can Work It Out, Understanding and Preventing Diagnostic Treatment Delays." As you all know, this is a very important topic as treatment delays can worsen TB disease and increase the risk of death, as well as enhance transmission to household contacts and community members. And we have some very great presentations planned for you today that will hopefully shed some light on the key barriers and facilitators to diagnostic treatment delays. We will have 8 presentations today, which is great because that actually allows for more time for each presentation. Each presenter will present for 6 minutes, and then we will allow for 3 minutes for individual discussion. And then at the end, we will end with a general discussion with everyone.
Wonderful. So we'd like to welcome the first presenter, Lily Bonadonna from the University of Michigan, and she will be presenting on the social determinants underlying TB diagnostic delay, a mixed method study.
Hi, good morning, everyone. Thank you for the opportunity to speak here today. So today I'll be talking about this project titled The Social Determinants Underlying Tuberculosis Diagnostic Delay, a mixed method study. So diagnostic delay, as our presenter said, it leads to increased transmission and increased TB-related morbidity and mortality. And in this study, we define diagnostic delay as the number of days between symptom onset and the first smear-positive TB sample recorded in a health post under regulation by the National Tuberculosis Program. So reducing diagnostic delay is a major global priority for control efforts, and it's emphasized in the 2015 the WHO and TB strategy. So this study we conducted in Peru, which has the second highest incidence of TB in the Americas region. And most of these cases are located in Lima, which is the capital city. If you look to the pie chart on the left, about 57% of cases are in Lima. So in this study, we aim to identify and characterize the social determinants that contribute to diagnostic delay. And we focused on the perspective of persons in treatment and their family members and their health personnel. We wanted to gain an individual, community, and health system level understanding of this phenomenon. And we visited 19 different districts in Lima. So the map highlights the different districts we visited from the northern to southern cone of the city. So this was a mixed method study, and it was cross-sectional. We used semi-structured interviews with family members and persons diagnosed with TB. And we focused on health-seeking behaviors, community perceptions of TB, and socio-demographic circumstances. And we also collected quantitative data with questionnaires. And then we did 6 focus groups with healthcare personnel who either worked in a health post serving persons living with TB, or they worked in the national TB program. So these interviews, they were recorded, transcribed, and then we analyzed using qualitative and quantitative methods. So these are our basic quantitative results. We found the median diagnostic delay to be 57 days, nearly 2 months. This graph here is in months on the horizontal axis. And these were the 6 factors that we found to be associated with diagnostic delay. So the horizontal axis is diagnostic delay, and we can see on the vertical axis the 2 groups that we compared. So older individuals delayed longer than younger individuals. Those with lower income delayed longer than those with higher income. Females delayed more than males. If you had less than 4 people living in your household, you delayed more. If you had more visits to professional health facilities, you also delayed more. And if you first attended a private clinic as opposed to a public health post, you also had a higher diagnostic delay. And these were all statistically significant. And this is our conceptual framework for our qualitative analysis. So if you see here on the bottom left, those are the signs and symptoms of TB. And then across the arrow is the time to diagnosis. So that's the diagnostic delay. And these are the 6 factors which intermediate in this time period. So I'm just going to go through each one by one and read the representative quotes through the qualitative analysis. So first A, we have material resources, time availability, and social support. So here a patient said, I waited because of work. There was no time. I returned in the night from my job around 8:30 p.m. And at this time, the health posts are not open. So this patient here has a lack of resources, a lack of time, and needs to support his family, doesn't have very much social support, so has a longer delay. And then in section B, we have the previous knowledge and experience with illness. And this patient says, I thought TB was for people who did not eat, for the vagabonds that didn't look after their things. So he has a low TB-related knowledge in this case. And this patient in particular did not have another family member who had had TB previously. So then these two factors then feed into part C, which is the threshold of symptom severity. So this is the threshold in which a patient then seeks treatment afterwards. So in the quote here we have, it came to the extreme. I threw up blood from my nose, my mouth, and I went to the hospital. So if a patient has low resources and low knowledge, they have a higher threshold, is what we're describing in this case. And then these three factors lead into the health-seeking behaviors. So we found that patients did one of four things when they finally chose to seek healthcare. They either took self-medication in a pharmacy, they medicated with natural medicine, they visited a private clinic, or they visited a public health post. So here the family member says they always go to the pharmacy and they say this or that and they get a diagnosis and a pill. It's faster. Sometimes there is no time to go to the health post. Here you have to work, and if you don't survive. So then after diagnosis, we find our final factor which contributes to diagnostic delay, which is the community and health system responses. So this is the stigma and discrimination that that we found many patients to experience either in the health post or outside in the greater community. So this quote here is from a healthcare worker. I had a patient and I asked him, why did you abandon treatment? He said the nurse left him the pills on the table and then everyone disappeared. Everyone left running. The patient said, why am I going to come here if they treat me bad, if I feel bad? A TB patient has low self-esteem, and with the treatment we give him, it gets worse. So this stigma and discrimination feeds back into the loop you can see here to increase diagnostic delay for future patients. So then this is some quantitative analysis to support our qualitative findings. So on the left side, on the darker gray side of the graph, are patients who first self-medicated either with pharmaceuticals or natural medicines. And on the vertical axis, you can see the percent of patients who did this. And then on the right side of the graph, there are the patients who visited either public health posts or private facilities. So then the top graph here compares these two groups, either self-medication or visited professional health facilities, and we found people self-medicated more than visiting professional health facilities on their first health-seeking behavior. So this supports the qualitative analysis I just described. So in conclusion, our qualitative data showed that when individuals reach a certain threshold of symptom severity, they adjust their health with the least time-consuming, most economically feasible and well-known healthcare option to them. And then in quantitative analysis, we showed that diagnostic delay is common, prolonged, and is influenced by several socioeconomic and behavioral factors. So what can we do about this? We recommend that active case-finding initiatives look for TB in places where patients are first most likely to go. So this is pharmacies, as I described earlier in our research. We also recommend that NTPs collaborate with private clinics, because that's another location where patients are often likely to first seek care. Thank you very much.
Thank you very much, Lily. We'd like to open up to questions.
I wanted to know if you have any reasoning why the number of people living in the household has an impact depending on the delay that you explained in the second or third one?
Right, sure. So we have a hypothesis that if you live with less people, you might be less likely to have social support and less resources within the household. So if you're living with one other person, you might be more likely to be the breadwinner of that household and have to work and not have time to go to the health post, so that might increase diagnostic delay.
Yes.
Charles from Nigeria. Thank you for you said that patients, go to pharmacies. In Nigeria, where I come from, we've done a similar study, and our diagnostic delay was the median of 90 days. We found out that the definition of pharmacies here, because in Nigeria we have what we call the patent medicine dealers. They are not registered, they are not professional pharmacists, but they are everywhere. Mm-hmm. And the first point of call of our patients with chronic cough, including TB, is this patent medicine. I don't know in Peru, they have such scenario. Are all these qualified professional pharmacists?
Right. It's a similar situation in Peru. So you don't need a medical prescription to get antibiotics. You can just, and most of the pharmacists aren't professional pharmacists. We have what's called boticas. So they just receive medications. So that it's not a professional health facility by any means. So it's a similar situation.
Thank you so much for that wonderful presentation.
Thanks very much.
All right, so our next presenter will be Hyeon Kim from Johns Hopkins, and she will be presenting on perceived barriers and facilitators of isoniazid preventive therapy among people living with HIV in South Africa.
Hi, good morning. Thank you for giving the chance to present our work on behalf of our team. Here are the list of co-authors, and I have no conflict of interest to declare. So given the uptake of the IPT has been poor worldwide, we aim to quantify the relative importance of barriers and facilitators for the uptake of IPT among patients. We conducted a cross-section study in 14 public primary health clinics in Matlosana sub-district in South Africa. A total of 342 HIV positive adults with a recent diagnosis of HIV within 6 months were presented in this survey. In terms of baseline characteristics, the mean age was about 35 years, and then about 2/3 of the participants were women, and the mean CD4 count was 298, and time since HIV diagnosis was 28 days. And about 56% was currently on ART, and 33% was on IPT initiated and or on IPT, and the mean travel time to clinic was about 20 minutes. And these characteristics did not statistically significantly different by IPT status. So based on the literature and qualitative interviews, we identified 16 attributes, the most related to IPT uptake, and used a stated preference method to compare how these attributes were relatively prioritized among patients. Here is the sample choice task. In each choice set, we asked the participant to choose the one that best described their thoughts and the one that worst described their thoughts. As you can see in the example, each choice set had 6 attributes, and each attribute was repeated 6 times across the questionnaires. Let's say that someone chose second attribute as the best, and the third attribute as the worst. Then the attribute chosen as the best was given the score of 1, and the one chosen as the worst was given the score of -1. We calculate the average score across all respondents for each attribute. Thus, the average score 1 means the attribute was chosen as best every time it appears across the questionnaires, and the -1 means it was chosen as worst every time it appears, and they're considered as the least prioritized attributes. The scores were stratified by current IPT status and compared using a t-test. So here are the results. On the y-axis, these are the 16 attributes shown from most prioritized attribute on the top to the least prioritized attribute towards the bottom. On the x-axis is the score from -1 to 1. The top 2 most prioritized attributes were that people with HIV can have the same standard of life as someone without HIV, followed by I trust that doctors and nurses know what is best for my health. Worrying about side effects or unintentional disclosure of HIV status were least prioritized in these populations. In general, we can see that the attributes related to benefits were more positively prioritized. Although the overall pattern was similar, we saw some significant differences by IPT status. For example, those on IPT more negatively perceived avoiding serious illness compared to those who were not on IPT. In this study, using a stated preference method, we quantified the relative importance of 16 qualitative attributes. Our study support having the same standard of life or long life similar to HIV-negative individuals, and trust in healthcare providers were most prioritized and important in this patient group. Previously known barriers such as transportation cost, stigma, or concern for side effects were less prioritized. The strength of our study is that we presented barriers and facilitated together and measured the relative importance as perceived by patients. Therefore, we believe that building a trust with healthcare providers and educating patients on positive benefits may enhance IPT uptake in future, and these results should be addressed to deliver IPT with a patient-centered approach among people living with HIV. With that, I will thank all our colleagues at Johns Hopkins and PHLU in South Africa, and thanks for listening, and now I will take any questions.
Thank you very much. Any questions? I was interested in the kind of that perceived need of healthcare that the patients had that was a facilitator. And so what do you think leads into that for patients? In terms of what defines their perceived need, or what determinants of a perceived need do you think?
Yeah, so I was surprised that also similar to the qualitative interviews, that they actually have a perceived very high trust in healthcare system, also the positive benefits, which is sort of the opposite of the known barriers, such as that in some countries that there is a low belief in healthcare system. But I think this is showing the direction that we can have a further intervention in terms of increasing the patient perceived benefits.
And as a follow-up to that, did you guys quantify in terms of what they valued about the healthcare system and which, if it was particular centers or?
Yeah, we didn't have that specific for that item, but we just had one attribute, because the 16 attributes are across different domains of the benefits. So we didn't have those specified details for that, but that's some certain thing you can look for.
Great. All right, well, thank you very much.
Thanks.
All right, next we have Ricardo Asensio, who is from the University of Sao Paulo, presenting on the cultural adaptation and validation of the TB-related stigma still in Brazil.
Hello, everyone. Here we have the work, Cultural Adaptation and Validation for Brazil, of tuberculosis-related stigma scale. Tuberculosis-related stigma has around interest in different regions around the world, including Brazil. Alongside biological, economic, cultural barriers to effective tuberculosis control, stigma represents one of the major social factors causing deepening suffering, exclusion, and unfairness, mainly in vulnerable groups. Who concerned with this issue has launched a campaign, Unmask Stigma, as a strategy to reduce the stigma. So, what is stigma leads? Stigma leads to fear, ashamed, prejudice, exclusion, discrimination, low self-esteem, haunted. This represents an important barrier for seeking TB care. What are the consequences of stigma? Diagnosis delay, treatment delay, low effectiveness of the treatment, default, suffering, drug resistance, and deaths. So, although the stigma has been a relevant problem in Brazil, it was not identified a valuable and reliable instrument to investigate that. To little reveal, we observed a tool developed in Thailand named tuberculosis-related stigma. However, this scale would not be valid to Brazilian context, not in its original version. So, with this study, aim to culturally adapt to Brazilian context and obtain the psychometric properties of tuberculosis stigma, tuberculosis-related stigma scale. For that, a quantitative methodological research was carried out divided in three phases: translation and back translation of the items, semantic validation involving 17 subjects, a pilot study including a sample of 16 Brazilian patients under TB treatment recruited for a referral outpatient clinics in the city of Ribeirão Preto, São Paulo states. In the three phases, statistical analysis appropriate for the instrument validation process were applied based on the method DZAB Kids group. So, in the back translation process, few terms were adapted to target culture. The semantic validations showed the participant good acceptance of scale. In the pilot test, no floor and ceiling effects were found. That means that the scale was understandable by Brazilian TB patients. The reliable and internal consistent showed Cronbach of coefficients of 0.55 and 0.52. What means moderate results? It's possible to improve these values through a field study. The multi-trait multi-meta-analysis for convergent validity show score upper to 0.3 for 9 items on the scale. So the preliminary results of the scale indicate the appropriateness of the equivalence between the original and Brazilian version in view of the linguistic and cultural variations assessed. Nevertheless, the initial psychometric properties indicate that the scale needs to be tested with a large number of the patients in Brazilian context. We are going to phase 3, field study, for analyzing whether this scale is appropriate to be used by healthcare professionals and other actors from Brazilian health systems. We hope that the scale can be used to be helpful by Brazilian health professionals as soon as possible for diagnosing stigma and to overcome the problem. Here, we have some pictures from neighborhood where the TB patients live. Many thanks to the authors of original tuberculosis-related stigma, Dr. Van Ree and Dr. Aaron Kipp, for support provided during the stages of cultural adaptation of the scale to Brazilian Portuguese. Thank you very much.
Thank you. I'd like to open to questions.
Yes.
I was just wondering what your plans were for the field study.
Excuse me?
What your plans are for the field study, for this follow-on study to the pilot study.
Yeah.
What do you plan to do?
Yes, absolutely. We intend to apply this scale in about 200 TB patients. This scale in 200 TB patients. But it's the sample, it's really, really big, considering the center in Ribeirão Preto. So, but I think that this scale is really appropriate to TB patients in Brazilian context.
Can I ask a follow-up?
Of course.
How many centers are you planning on doing the field?
Oh, this is good questions. Yes, we intend to expand to other centers, specifically in the northeast of Brazil.
Yes.
I'm from Peru, Rio de Janeiro. We've done a similar study with indigenous population, which obviously presented some different challenges. Are you thinking about expanding this to include all aspects of the Brazilian population? Or are you focusing only on Sao Paulo and the Northeast?
Yes, it's possible because the selection of scenario is for convenience. So if we have a partner in Rio de Janeiro, probably we'll carry out our research there.
Because our problem is that we don't have enough patients to do a proper sample. So that's one.
Great, great.
We have time for one more question.
What were, in general, what were the differences between Thailand and what you decided on?
Because this original instrument, we didn't identify exception by the language. We didn't identify difference between the original version of the scale with a Brazilian context. We didn't identify difference between of the scale, unless in terms of the language.
Thank you so much, Ricardo.
All right, so next we have Leonardo Martinez explaining the delays of tuberculosis dynamics in patients from a TB referral hospital in southeastern China.
Awesome. So my name is Leo Martinez. I'm going to talk about a diagnostic delay in Nanjing, China. So the rationale for this study was talked about a little bit before. Some of the adverse outcomes of increased delay are increased community transmission, and it can also lead to more severe individual disease for that patient. And so globally, approximately 1 in 3 TB cases are missed by healthcare services and remain undiagnosed. And so to control the epidemic, diagnostic delay is a key component. So our study objectives in Nanjing were to calculate the total diagnostic delay, which is defined as symptom onset to confirmed diagnosis, and to find factors that were associated with increased delay. And then we also wanted to, we wanted to find which patients were most likely to delay, and also where patients turn to for help in the healthcare setting. So this is just a description of each patient. We had a little bit less than 200 patients in total, and this was in a TB-designated hospital in urban Nanjing. And so the mean delay was approximately 50 days from recognizing symptoms to tuberculosis diagnosis. So these were done through structured demographic questionnaires. And so we found some of the same variables as was discussed earlier, but if you were female, so this is also, I guess I should explain, this is, these are hazard ratios. So if you have a lower hazard ratio, that means you have a later diagnosis. So if you're female, that means after multivariate analysis, you're more likely to have a later diagnosis. Also, if you lived outside Nanjing, it was suggestive, but then it was not statistically significant after adjustment. And then if you reach the healthcare system quickly after symptom onset, then you were also likely to go through the healthcare system very quickly as well and get diagnosed. And as we're going to see in the next couple of slides, getting in quickly and getting to the right place was very important in this setting. And other variables, such as age, marital status, smoking status, and having other comorbidities were not associated in this study. So during our surveys, we also asked where patients went to after they had symptoms. So we asked where they went first, and then where they went after that, and so on, until they got diagnosed. And so I guess important to mention is that Nanjing Chest Hospital is the TB designated hospital in Nanjing and is the only place that can confirm diagnosis, at least in this part of the city. And so all these other settings, they can refer to this hospital, but and they can classify individuals as TB suspects based on radiographical results and symptoms, but they can't diagnose. And so what we found was, if you look at the graph, the black bars are the first visit, and the white bars are where they had multiple visits. So you can see the first visit was predominantly, after symptom onset, was predominantly to public hospitals, and then they repeated in public hospitals fairly often. So this was definitely a setting where the patients recycled in the healthcare system without reaching a diagnosis. And so Nanjing Chest Hospital is the second one, and is where everyone got diagnosed. So we found that, so just to conclude really quickly, we found that female patients took significantly more time to reach diagnosis, and that patient cycling in the health system was very common. And so this probably leads to some nososomal transmission in the healthcare system. And so improvements in prompt referral from public hospitals may assist in having these patients diagnosed quickly. Thanks. Thank you. And this is just the team that worked on the project in Nanjing with me.
Thank you. Any questions? Go ahead.
Hey.
My name's Steve Neary, I'm with Project Solar. I have a couple questions for you.
Yeah.
In your analysis, I would imagine that the severity of someone's symptoms would prompt them to show up more quickly. Did you have any way to measure that as in terms of, I guess, the delay to get care?
Yeah, we asked some questions about that. There was some issues with like recall bias. A lot of patients, because of the length of time it took for them to get diagnosed, didn't remember a lot of key aspects, such as like specifics about their symptoms. But definitely, it's a good question. Yeah.
And then I have a follow-up question. Did you have an average number of days from when they presented at the facility to diagnosis, rather than, or did you break that out?
Yeah, we did break that out. I don't have those numbers here in this presentation. I'm trying to remember, and I don't have the exact number off the top of my head. But we did break it out into like health system delay and then total diagnostic delay also. But I can look it up after and tell you.
Okay, I think I'm asking that because I think both are very interesting in what happens at the community level.
Yeah, especially because of this slide, especially if there's lots of recycling, health system delay is probably pretty crucial also. So yeah, definitely really important.
I think the hand back there was first. Yep.
Hey.
Did you try to find out as to why female patients had more delays as compared to male patients?
No, we didn't. We didn't like re-follow up with the patients and ask. Basically, it was just asking about where they went and how long it took them to get diagnosed. We didn't have like a qualitative aspect like the other study, but it definitely would have helped a lot.
Thank you so much. We're going to have time at the end for more discussion, but I want to make sure we get to everyone else. So thank you.
All right, so next we have Eric Musafiri from the Democratic Republic of Congo, and he will be presenting on predictors of delay in tuberculosis care in South Kivu province in DRC.
Thank you. Before I apologize for my limited English, thank you to the organization to give us this opportunity to present our study, predictor of delay in seeking tuberculosis care in the South Kivu province in Democratic Republic of Congo. Tuberculosis remains a global health threat. In the Democratic Republic of Congo, South Kivu is a notification rate and success rate are about 57 per 1,100 and 80% in 2014, respectively. We aim to investigate the knowledge, attitude, belief about risk factor for TB and determine the seeking TB care. South Kivu is a big province, around 65,000 kilometers square, population around 7 million, and we have 150 health centers, diagnosis tuberculosis, around 628 health facilities, and we have 10 sets of joint experts. We performed in the interview at 23 centers from the diagnosis tuberculosis from January to March in 2015. The scopes data were summarized using means and proportions. K-square test was performed to compare proportion and logistic regression to identify independent predictor in interest. Stata software IC version was used for all statistical analysis. Research Ethics Committee approval of the study were obtained by the University Catholic of Bukavu. Uh, 82 patients on the TB were interviewed, mean age 40 years, 41.5% of female. Delay in seeking care was documented at 3 months. Predictor of delay in seeking TB care were familiar, living in rural setting, and low education level. Patients were old or living in a rural setting were more likely to seek TB and report symptoms as such chronic cough. Familiar, rural living patients and poorly educated patients were found to be associated with delay in seeking TB in our study. However, the late two risk factor did not reach statistical significance due to limited sample size. A big study to confirm the result is warranted. Scaling up targeted community-based to intervention, e.g. active case finding, mass education compounds, male TB outreach services, and timely linked to treatment center are sorely needed in this setting. We thank you, the TB Challenge. We thank you, the NTP Congo Democratic. We thank you all as a team. Thank you.
Great. Open to questions.
Yes.
I'm just seeking some clarification on the methods you used. You said in one slide you used in-depth interviews in 23 centers, and yet you presented very quantitative data. So I'm just wondering how to fit.
Okay, good. We worked in 23 health centers, but our interview was oriented to the patients. So we interviewed 82 patients in 23 health centers. Yeah.
Okay.
Mm-hmm.
And did you use a questionnaire or?
Yes, we used questionnaire. Yes.
Rather than an in-depth.
Yes.
Okay.
Mm-hmm.
Great. I'd also had a question about clarifying the association with gender. So did you see that they say that females were associated with delays in care or actually improved seeking of care?
The female gender was found as in delay seeking to reach the health center. Maybe it is about culture, it is about occupations, it is about low level education also. And I think in our country we have many problems around according to survive. So women are likely involved to go to look some things for it, and it become a problem for her to reach early the health center.
There was one more question back there a little while ago. Do you have a question?
Well, I think it's been covered.
Okay, great.
Because just previous to the previous presentation, I find it very strange that the agenda for women seems to be coming up again, seeking earlier, whereas in many publications, it's really shown that the men, when it comes to health behavior, it's really, the men that's a problem. But your presentation and the previous one shows it's women. It's really kind of
Thank you so much for that comment. We're actually hoping to cover that in our general discussion. And so let's save that conversation for that time. I'm going to take one more question over here.
I would like to ask for clarification how you, do you have any criteria to pick up 82 patients? Because I saw from your presentation that the female accounted for like 41% of the participants in the interview. Is it like correspondent to the ratio of men to female among the patients, TB patients? Thank you.
Yeah, thank you. Our criteria was all patients who were taking drugs during our period study. So the interviewer were in the health centers and waiting for all patients who came to take drugs. And so they asked for accepting to participate in the study, and where we found that males were 41.5% participate. Yeah.
Okay, very quickly.
Those who consented were 82. So out of how many? In other words, the response rate was 82 out of how many of patients who are taking treatment within the study period?
All of them.
82.
Yeah. I don't well hear the question.
Okay, thank you so much for your presentation. And we're going to move on to the next presenter.
Thank you.
All right, next we have Kruger Kaswaswa from University of Malawi on anything to do with TB is dangerous, exploring barriers and uptake to household TB screening, intervention in Blantyre, Malawi.
Thank you, Chair. I'll be presenting work from Malawi. This is work that has been done by the Malawi National TB Control Program in collaboration with the College of Medicine, Malawi Liverpool Wellcome Trust, and the HESNOD initiative, exploring barriers to uptake of household screening interventions in Malawi. Having said that, so why exploring barriers and perceptions in TB screening? 54% of TB patients in our main screening study declined to participate in the study, and there is high TB and HIV burden in Blantyre, about 11.4%. But also there is low rates of screening, and there is also suboptimal uptake of IPT and under 5 screening in Malawi. And then the reasons for non-participating have not been examined in Malawi. And we did a qualitative study whereby 50 participants in the main parental trial were purposely recruited, and we did 16 in-depth interviews and 3 focus group discussions with patients, staff, and trial workers. And we did include 8 non-participating participants in serial with serial IDs. 4 were females and 4 were females. Their HIV status was positive. So this was a qualitative study, and NVivo assisted us to try to analyze our data, and by using mixed content analysis, and we did triangulate our data. And the framework as shown in this slide. So what motivated participants not to screen their households? There were several reasons, and one of them was individual level motivation. This is because as perceived by the benefits of access to TB education and the treatment, and I caught it. I like it because I have gained back my health because I have found out what I was suffering from TB. This came out from the TB patient of whom we interviewed. But also, TB was considered to be valuable information as regards to participating in this. But also, we saw that convenience and avoiding related financial costs was one other factor that motivated people to partake in screening households. But also, issues that had to do with the households in terms of dynamics and willingness of the household to screen the willingness of household members to have their households screened. But what prevented patients from screening their households in Malawi? We saw that one of them was patient health condition and cost as well. So poor health conditions or perceived financial burdens automatically forced somebody to decline not to screen his or her household. So some people don't participate to say, I don't have transport money. I won't go if I'm told to visit the hospital. So this clearly came out from one of the participants, from the focus group that we had as regards to failures in terms of participating in screening the households. But also there is what we call community branding. Home visits discloses a considered TB diagnosis which attract discrimination from household and community members. And I heard people say that when you participate, the health worker visits you and everyone surrounding you becomes aware that you are suffering from TB. So I had to protect my health status by not participating. This was a male index patient trying to explain that there is some kind of branding that will be associated with partaking in patient-delivered household screening. Patient fears, misconceptions about screening was another factor that we identified. So in marriages, especially the youth, they don't seem to accept it well. They think that if you give a sputum, it's not inappropriate. Others said we will diagnose them when we take their sputum, even if they don't have TB. They're just scared to say that anything to do with TB or TB equipment is dangerous. So this is one of the concepts that came out from the non-participation to screen their households. So another factor which we saw is the health system itself was lacking privacy and confidentiality. It came out clear that I think the health systems that we have in Malawi doesn't support confidentiality and amenities, privacy and confidentiality. And we did call that. What makes people not to participate in TB screening is that TB officers are few, so they found out that they get occupied. Maybe the patients that need injections are a lot. You find that you have forgotten to ask if patients have a child under 5. So this came out from the focus group discussions with the trial personnel. But also there's poor communication with from healthcare workers. And we did quote, I just started treatment. When they saw me, they told me I have TB. And then I started treatment. I don't remember them explaining to me about home screening, except from the ART clinic, because TB and HIV, they are related. They are the ones that explained to me. But about TB screening, I don't think they explained. I don't think they explained anything to me. This was a male patient who did not participate in this. So some of the key conclusions in our sub-study is that you can do a patient-delivered screening at household level, and it's attractive at community level, but we need to improve further if we want to work on this. Privacy and confidentiality are critical issues as far as screening is concerned, but also catastrophic costs remains a major barrier amongst TB-affected families who are seeking for TB screening services. Implementation of household screening requires the development of tools that are patient as well as health-friendly system. I would like to acknowledge the foreign people who assisted us to run this project in Malawi. Thank you.
Thank you so much. I'd actually like to start with a question. What interventions would you propose to improve confidentiality?
Come again?
What interventions would you propose from the healthcare system level to improve confidentiality for patients?
I think there would be several, you said interventions? Mm-hmm. In my opinion, I think improvement of infrastructures is one of them. Training could be one of them. But also, if you look in our setting, I think if you create demand for screening, then there's a lot of clients that are coming in. So you need to put in place in terms of infrastructure, in terms of space, in terms of amenities, so that I think the screening itself has to fit in with privacy and confidentiality. That's my perception.
Other questions?
I can't remember exactly the quote, but there was one quote, I think from the male index client. It sounded like he didn't have a lot of education on the importance of TB screening because he was more concerned about the stigma than the TB screening. Were you finding, or did you have any qualitative results on people understanding the disease? Do you see my point? Because he wasn't seeing the benefit of the screening because maybe he didn't understand what it was for. That's kind of how the quote struck me.
These patients who did not participate, they realized later that I think what was more important to them was the health information that they are gaining. So to them, they felt that, wow, we got the information that they get from the TB screening initiative itself, which is being done by the household, would be far much more important. But however, there is also an underlying factor, which is catastrophic costs. So I think to them they thought
outweighed the
risk.
Okay.
Exactly.
Yes. Actually, I have a comment more than a question regarding the question the chair just asked you regarding to the intervention to protect the patient confidentiality. I think that firstly we need to have a law to protect the patient confidentiality. And the second thing, that is the application of the law at the facility. That like when employee get into the facility to start employment, they need to like to be educated about the confidentialities of the patient information, and also they maybe like there's some sign at the facility to remind both the healthcare worker and also the patient that the patient information confidentiality need to be like protected. So I think in that way it will work.
All right, thank you very much.
Thank you.